Welcome to Pulse Pressors, where critical care gets crystal clear. The Mitral Clip is a transcatheter edge-to-edge repair (TEER) system designed to reduce mitral regurgitation by approximating the anterior and posterior leaflets. The procedure is performed via right femoral venous access, followed by transseptal puncture to enter the left atrium. TEER provides a durable alternative for patients too high risk for open surgery. Mechanistically, the clip grasps the A2 to P2 leaflets at the origin of the MR jet, creating a double-orifice mitral valve to reduce the severity of the regurgitation. This reduces the effective regurgitant orifice area, increases forward stroke volume, and lowers left atrial pressure. These changes translate into improved symptoms, reduced pulmonary congestion, and better hemodynamics within minutes. Indications depend on etiology. Degenerative mitral regurgitation requires favorable anatomy and elevated surgical risk. Functional mitral regurgitation requires symptoms despite guideline-directed medical therapy, also known as GDMT, or cardiac resynchronization therapy, known as CRT. The coaptation trial, cardiovascular outcomes assessment of the Mitral Clip percutaneous therapy for heart failure patients with functional mitral regurgitation, demonstrated that select patients with functional MR gain survival and hospitalization benefits from transcatheter edge-to-edge repair or TEER. Contraindications include rheumatic disease, severe leaflet or annular calcification, excessively short posterior leaflets, pre-existing mitral stenosis, or active endocarditis. These anatomic or infectious factors compromise leaflet capture and durability. Anatomy governs candidacy. Leaflet length, coaptation depth, coaptation length, and absence of calcification determine procedural feasibility. These structural details dictate whether the clip can grasp deeply and securely enough for durable reduction of MR. TEE is the procedural roadmap. X-plane imaging ensures perpendicular alignment to the leaflets. The 3D end-face view provides a surgical perspective of the mitral valve MR jet mapping, identifies the optimal grasping location. Left ventricular outflow tract LVOT views confirm coaxiality and prevent leaflet tethering or malorientation. Positioning begins with targeting A2 to P2. This often corresponds to the main regurgitant jet, especially in degenerative disease. Orthogonality to the coaptation line ensures symmetric leaflet capture. A secure grasp requires greater than 5 mm leaflet insertion on both leaflets and preserved independent motion. Hemodynamics determine true procedural success. With MR reduced, left atrial V waves fall, forward stroke volume increases, and pulmonary venous congestion improves. However, transmitral gradients must remain below 5 mm of mercury at physiologic heart rates to avoid iatrogenic mitral stenosis. Success is defined by physiology, not cosmetic reduction. Mild or mild-moderate residual MR is acceptable. A 30% V-wave reduction, improved left ventricular outflow tract, LVOT, velocity time integral, VTI, and stable gradients confirm improved forward flow. Multiple clips may be necessary in functional MR with large annuli or in degenerative disease with broad prolapse segments. Medial or lateral residual jets require targeted clipping. The overarching principle is reducing MR while protecting transmitral gradients. Red flags include elevated gradients, single leaflet device attachment, loss of leaflet insertion, or persistent MR with high V waves. These findings demand reassessment and possible repositioning or addition of another clip. Post-procedure care focuses on gradients, LVOT, VTI, and volume status. Hypotension may unmask LV diastolic dysfunction that was previously masked by regurgitant unloading. Managing atrial fibrillation becomes critical because forward flow now matters more than before. Access management is essential. Right femoral venous access requires closure devices or manual compression. The patient will need to remain flat for several hours. Post-procedure, aggressive IV hydration helps flush contrast dye and protects renal function. Patients begin dual antiplatelet therapy for 1 to 6 months, depending on anatomy and bleeding risk, followed by lifelong aspirin. VTE prophylaxis is required due to procedure length and immobility. A key differentiating feature of TEER is its extremely low risk of conduction block. Unlike TEER or tricuspid interventions, Mitral Clip implantation does not involve the AV node or his bundle, so pacemaker implantation is rarely necessary. Hemodynamic pitfalls include overclipping, leading to functionally significant mitral stenosis, recurrence of functional MR due to progressive annular dilation, persistent elevations in LA pressure due to non-compliant ventricles, and RV failure that persists despite MR reduction. When TEER fails, the patterns are predictable: SLDA from inadequate leaflet capture, recurrent MR from progressive annulus or leaflet degeneration, or lack of LV reverse remodeling in severe heart failure. Management includes redo TEER, surgical intervention, or advanced heart failure therapy. The essence of Mitral Clip mastery is recognizing that this is a procedure of anatomy, precision, and physiology. The goal is not to eliminate MR entirely, but to restore forward flow while avoiding iatrogenic stenosis. When executed properly, TEER transforms hemodynamics instantly and sustainably. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.